Hi, I'm Robert Schlosser, and this is a project dealing with rapid response teams. There's indications for activation and overcoming barriers. There's a list of objectives that I'd like you to take as a self test. If you would first try to name one reason that you would call for a rapid response team. Secondly, give one event that you feel would require a code blue page as opposed to a rapid response team. And how is SBAR used in rapid response? And how can you overcome barriers to an RRT initiation? The purpose of an RRT is a rapid response team activation. And there's a few reasons to call those. You would ask for an RRT to prevent cardiac or respiratory arrest outside of critical care. You would ask for one to prevent an incident of failure to rescue. Now, failure to rescue is a process where you know that your patient is deteriorating, but you do not ask for assistance and you allow them to continue. This is a criminal offense, actually. So we must do our best at all times to monitor, assess the patient, and treat them as needed. We also would use an RRT to improve outcomes of the deteriorating or unstable patient with a rapid multidisciplinary assessment and intervention. You're not asking for one person to help you. You're asking for a multitude. You're asking for a respiratory therapist. You're asking for an intensivist. You're asking for the nursing supervisor if you need assistance for bed. These are all to help you. You're not alone when you have a patient that's going bad. Now, two things to consider here is whether to call or not to call. Now, this is a combination of our hospital's policies and general policies. So first of all, can the patient wait for response from your primary MD? If yes, then just call your attending and you can get any orders that would appropriately care for that patient. If no, you call the RRT and then you place a call to the attending physician. You always let your attending physician know regardless. Reasons to call an RRT. Respiratory distress is the number one reason for an RRT to be called. Secondly, acute and significant bleeding. If there's new neurological changes, which would be stroke symptoms, confusion, or lethargy. If there's sudden, severe, or increasing pain. If there's unrelieved angina or arrhythmia. If there's severe sepsis or septic shock. Any acute change in vital signs or your assessment. Or if the nurse or family member is just concerned about changes in your patient's clinical status. The family may ask you to call for help. And if that's the case, then you should call for help. And last, DNR does not mean do not treat. You can call an RRT for a DNR. They just will not be coded. Now, before requesting the RRT, you should check for adequate pulse and respiration. Prepare yourself and your assessment of the patient. Use SBAR. And SBAR is your method of passing off information from a hands-off scenario to the oncoming group, including the intensivist who will be seeing the patient. Another reason to request the RRT is sometimes you just have a nagging concern that you can't put a head on what the problem is. And those concerns are an unconscious application of your assessment skills. You may not logically understand a sign or symptom that you're seeing, but the overall impression is that the patient is deteriorating, so you would call the RRT. But you're always the first line in patient safety. You're the first person that does the assessment. You're responsible for that. You are the primary nurse. And lastly, Your RRT request is called for the best outcome of the patient. RRTs have proven to enhance outcomes of the patient in a clinical status. Now, one other option here is you could skip the RRT and go right for a cold blue if the patient lacks effective heartbeat. If you assess them and they have a very weak or absent pulse, severe hypotension, generally under 80, but 80 to 90 is also considered pretty severe hypertension, or the ability to obtain the high blood pressure, or any lethal rhythms, you would call code blue. Now, in our facility, you can call the code blue even though there's a pulse, but it's when it's going to be extremely possible that you're going to lose that pulse. Don't be afraid to call blue. It can always be canceled. So if you're in doubt and it's very close to a severe arrest, call that code blue, not the RRT. If your respirations are unable to sustain life, respiratory arrest, agonal breathing, which is a slow, shallow, or gasping rate, is less than 8, or above 38 for our hospital, and then again is based on your baseline of the patient. Some patients are at 40, and that's as they progress, their rates may increase. Or severe cyanosis or duskiness, and that would include modeling. Or some other life-threatening events, code blue, if you're really worried about an impending code. Now, other considerations within RRT is BiPAP can and should be initiated when ordered, but the internist must be consulted ASAP. And again, BiPAP is positive pressure, a machine that aids in breathing of the patient. It decreases the carbon dioxide and will generally allow you to sustain a good breathing pattern until they're intubated if need be. You would call intensivist if the FI2 is greater than 60%, and that's if you're on the BiPAP and you have auxiliary oxygen being placed. If you have to titrate up to 60% or above, the intensivist should be notified for further commentary and possible placement of an AT tube for intubation. Early signs of respiratory distress is increasing oxygen need. And then if you're having to titrate from a nasal cannula to a simple face mask, as you progress, these are signs that your RT is needed. Tachypnea. Now, generally, everybody considers 20 as a normal respiration, but the key thing is to count your respirations. And as it progresses past 20 to 30 to 40, these are all indications that you should be calling for assistance. Look at your baseline. And tachycardia. Normally, tachycardia is over 100 for sinus tach, but there's many other arrhythmias that are atrial fibrillation. Any tachycardia up from 120 on is we would consider that very indicative of impending chaos. And you have to watch for accessory muscle use, diaphoresis, if there's an altered level of consciousness, or if they're just speaking in 2 to 3 word sentences. These are all indications of a hypoxic patient. Even if you don't have your oximetry reading, these are indications of lack of oxygen. They have color changing or tripoding. They have to support their chest, 2 hands on the table to try to breathe. That's tripoding. Now, for the primary nurse, their roles and responsibility are varied. And again, you're the one that's calling for the assistance. Activate the RRT, but remain at the bedside, be available to tell the staff that's coming in what is going on. What have you seen? What are your signs? Now, we have an acronym called VOMIT. It's easy to remember. It's a word we see in the hospital frequently. The V is the vital signs. Check your vital signs and note the priors of any abnormals, especially acute changes. oxygen, and we always check the end tidal CO2. The RT will usually check the end tidal CO2, but many hospitals have the capability for nursing now to plug it into the side of the IV pumps. And you should be doing that for PCAs, or if you're possibly doing conscious sedation, we're doing end tidal CO2. That's prong, it goes in the nose, and it's normally between 25 to 40. If it's too high, that means your patient's CO2 level is rising. It could be from hypoventilation. It could be because they're on too high an amount of oxygen if they're a COPD. These are all things that you need to know. Then the M is a monitor. We always attach the monitor to Zoll. Even if they're on a heart monitor that sends up to the front to a bank, you want to know what's going on to that patient at all times. So we put the Zoll on. That way you can see if there's an arrhythmia. Then you need to have IV access, so make sure you have that. And then we usually get a 12 lead if there's any cardiac arrhythmias, chest pain. And we always check the glucose. With any time there's a change in mentation, you automatically have to rule out a low blood sugar. And then again, we use the SBAR, and we'll explain SBAR further on. But you'll present your SBAR to the RN who's coming, the RTRN, and the intensivist. That you have to be sure that you document what you've done. We in our facility, we have an RRT form, and you always have to reassess your patient. Even if the physicians and the nurse come in, reassess. When everything is said and done, you never know if they're going to reverse after you've done something to correct it. And then finally, code blue. If you have it, you need to initiate your compression and your ACLS as possible as your profession allows you. Now, SBAR. SBAR is a method of reporting off that they found to be one of the finest ways. It's short, it's streamlined, it makes all of your data readily available, and you will always be able to present the information in a more formal manner this way. It's right at your beck and call. Now we use the for our situation SBAR as situation, background, assessment, and recommendations. The situation is, why was the RRT called? It's very straightforward. You called for shortness of breath, you called for low blood pressure, whatever. In the background, we have the admitting diagnosis, the pertinent problems and abnormalities. The assessment is what was seen, your sign and symptoms, and your vital signs. And the recommendations is the interventions and the patient response. SBAR is best practice, and it's the most efficient method of giving a report. And one of the primary issues with my project is overcoming the barriers to effective RRTs. Use effective communication. Prepare your SBAR report and have it ready for your responders. Stay available. Your impression and assessment is vital. They need to know what's happened. They need to know quickly. Exercise critical thinking and teamwork. Your partners will be caring for your other patients. You can stress the care of the patient that needs you immediately. You would watch for trends and alerts that are built into your electronic charting. They will promote you. They'll tee you off. They'll give you little hints that there's something going on with your patient. It's built into the charting. You can see trends on vitals and labs, but the electronic charting is very helpful now. And you need to expect your responding members to be professional and non-judgmental. They will. Just assume it. There's no reason to feel inferior. Every nursing consists of many degrees of expertise. Don't be afraid to call for the help. Intuition and instinct are nursing skills. Don't delay if it feels wrong. Delaying causes damage to the patient. And again, we'll go over if you want to, for our self-test, if you can name one reason to call for a rapid response team. Give an event that requires a code clue being paged. How is it used in rapid response? And how can you overcome the barriers? My references, and thank you for your attention.